I tend to get a bit excited when I'm up here. And if you have trouble with my Australian accent, don't be afraid to interrupt me. But I was reminded that the international translation of words does change. And we were on a game drive, and Professor Nordin won't mind me saying this. Our driver at the time said, about the rhino. She said, we collar them. And of course she was saying we put a collar on and a GPS, but Professor Nordin thought it was colour them. And so she was looking for the pink rhinoceros. So things do get lost in the translation. And certainly with my accent, I do apologise. As a radiologist, we get a biased opinion of the world. We're in a dark room, but I guess when one comes out of the dark room, you see the clinical reality. And I think if I can present just a few things to you today, I'd like to have this message to you. And that is that when you're in a local area such as you are, and you do your job to the best of your ability, and you aspire to the local community, as you all do and as I have seen, you're in fact world class. And you're not a second-class citizen because you don't have the CT and you don't have the MR. Absolutely not. And what I've seen here, I congratulate all of you on your dedication to your work ethic, and of course the end result is that we help people who need us. Imaging is expensive, and certainly not without its issues of being, I guess, as I'll quote later, sometimes misleading. But plain film X-rays certainly are important, and I will try and, I guess, find our way through, what's that happen here? Through these modalities. Something happened there, Jeff, I don't know what, I think I just crashed it. All right, I think I just crashed it. There we go, it's cool. Healing hands. Even though it's an apple, I'm allowed to say that. But certainly through the myriad of imaging, plain films are still fulfill a role today. And I think what I perhaps might like to do is give you a quick quiz. Okay, I want someone to tell me, probably a radiographer, to name this country what this bone represents. Australia, thank you. I've been looking for a bone that looks like Botswana. I have yet to find it. I've had my residents trying to find one. They haven't found one yet, but I know there will be one. I know there will be one. But certainly in my country, just north of Newcastle, we are very lucky. We're a very busy hospital. We're a 750-bed hospital, and we service further 6 community hospitals outside of that. And plain films are important. Let's just take a simple case of osteoarthritis. It's simple for the radiologist, but it's complicated for the patient. And I think one of the things that you learn with imaging is that what you see on imaging is not necessarily related directly to the patient's symptoms. And that's the difficult job of all clinicians. And as a radiologist, I try and help that. There are issues related to plain film radiography which make it difficult at times to rely on it. You should know that 30 to 50% loss of bone density has to be done, has to be taken from bone before you can see that change on a plain X-ray. 30 to 50%. So if we have a patient who's got malignancy or other red flag conditions, then plain films can be misleading like that. And that's why these other imaging fulfill that particular role. So I've shown here just an example here of an X-ray that just shows loss of disc height, the slight anterior slip of 2 vertebrae, which initially might be thought to represent, perhaps in the setting of trauma, a fracture or something like that. In fact, on CT, we can show that the facet joints here do have arthropathy, and this, of course, relates to having possibly a small canal, which we would call spinal stenosis, and possibly might end up creating cord compression. And of course, it also, as I said, can be quite misleading. And this patient here was told after an injury they had a fracture, but of course they don't. So we have issues relating to sensitivity, but we also have problems of interpretation. And does anyone know what this might represent, this line running across the bone here? It looks like a fracture. In fact, it actually is nothing more than osteoarthritis in the lateral joints here that's superimposed over the bone. And this often is a problem when you don't have a lot of specialist backup. I sometimes don't get to look at these images 24 hours after the event, and meanwhile the patient's been admitted to the ward with a fracture. So we learn very quickly that it has its limitations and also has difficulties with interpretation. And so when we have available things like CT and MR, my clinicians are very quick to go and have these studies done. And I don't think that's a good indication to do that, but certainly we have those issues. So if here in Modalities, I'm sorry if I'm not good at my pronunciation, you did get a CT, it would be there and everyone would want a CT. That's not appropriate, is it? I mean, no, everyone doesn't need a CT. And so these are the issues we have to try and work through. Okay, we'll just move on just a little bit. Now I know that there's an MRI at Francistown. We saw in Gaborone that also there are MR. And it's the same issue there. You know, how would we all like to have an MRI in this village here? We'd all say, oh, it'd be great. But of course, availability brings with it the responsibility of using it correctly. And I'm sure the people from the Ministry of Health would be more than unhappy if in fact we started overusing it. And so these are the issues that are difficult for superintendents of hospitals who are under cost control and your clinicians. It's always this difficult balance. And I spend most of my day actually trying to sort out when we should be doing it and when we shouldn't. And certainly with my clinical colleagues, we often have heated discussions about whether or not an MR is appropriate. And of course, they always say to me, well, we're the clinicians, we know what's going on, you haven't touched the patient, we're the one who wants it, we get it. And they do win in the end, okay? They do. But of course, what we're trying to do is rationalise the use of our health dollars and also for the patient. Because the expectation of the patient is what? I've had my scan doctor, what's wrong with me? And too often the imaging is I guess sometimes a bit misleading. Okay? We can see a big disc degeneration, and in fact that's not the problem. Okay, so one issue that I think's come up, and I rely on Jeff a little bit here, is that in radiography in particular, and I know a few of you here are radiographers, when we look at the spine, there's been this issue about whether or not we should take spine x-rays standing up or not. And of course there are technical radiographic issues about standing patients up. You don't get the quality of films that you get laying down. You don't have the control on the patient. And of course it does sometimes stress the machine a bit more because you don't have the tissue compression. And of course that means the machine might be under more load and you might have more problems with that. But there are things in the spine that are important to look in the upright position. For those patients who don't have red flags, for those patients who don't have history of infection, tumour, whatever, and looking for degenerative causes or possible roles, and particularly for those who are then going to do the treatment, things like this become important. I've used this one example here of a patient who, in a recumbent position, laying down, has good alignment of one vertebra relative to the next. You stand them up, and suddenly you have an anterior slippage here. And of course, this relates to possible stenosis, narrowing. It's not always the cause, absolutely not. One has to correlate with that history. You know, is their pain worse after standing up for an hour or two? Does the patient have nerve compression symptoms? All of those things become important. So the use of upright x-rays, okay, in the conservative treatment area is actually, I mean, there's been no great studies about it, but certainly for things like this, it can be very helpful. Okay, and of course, this is what we see on the MRI. Okay, patient in this particular study is in an upright MRI. Okay, we don't have upright MR at all. I don't think even in the southern part of Africa, but in North America it is a phenomenon now that there is a machine you can do upright MR, and this can produce some degree of increase in the narrowing, which you can all see here, and of course might be related to the patient's symptoms. However, we've still got to make sure the correlation of the image to the patient has to be done. Otherwise, it can be very misleading. Okay, and of course this phenomenon of central canal stenosis, is well depicted on CT and MR, and this is just an example of that. Okay, here's a case here which was a very interesting one. I'm the radiologist for the, not only the orthopaedic department, but also the rheumatologist. And this is a patient who was told they had a condition of the spine that would result in them being immobile for the rest of their life, and they were given the diagnosis of ankylosing spondylitis. Now, I don't know, is that a common diagnosis in this part of the world? Ankylosing spondylitis? No? No? Okay. But this patient here obviously has growth off the front of the spine here. We call it, I guess, a fairly long-winded name. You can just use the word dish. It's a common word we use. It's the second most common degenerative arthritis of the spine. It's a very characteristic disease. And I know, Jeff, you've already shown me a couple of x-rays that have come through the clinics here. And of course, for a therapist, and I know we have physiotherapists here, this can make a difference to how you treat. So the x-ray here, although there may not have been any red flags, there may not have been any true pathology indication, examination would have shown restriction of therapy, or movement rather, which for a therapist might make a big difference to how you're going to manage this person. So this is actually a fairly common one. In my hospital, when we see this, we have three questions. The first one is, do they in fact have DISH? And of course, there is a disease, ankylosing spondylitis, that is different. So we may have to make that determination. The second one, which may surprise a lot of people in the room, 8% of these people have diabetes. 8% have diabetes. The patient presents with neck pain, and suddenly we can look at this and go, hey, 1 in 12 chance, we better make sure we check them for diabetes. Okay? And the third thing, of course, is that they can break. They can break. They're very strong, but they can break. And when they do, these particular bone formations can create quite a lot of bleeding. We've had more than one patient who has had a large amount of bleeding from fracture of these. Now, that's in my hospital, where we are a big trauma centre, multiple, motor vehicle accidents, that type of thing. So, if you're not involved in major injuries, you're not going to get this. Can a therapist who mobilises the neck break these? It's never been documented, okay? And having been to a couple of surgeons, I know we've got some spine surgeons here. How many have removed some hyperostoses off the front of the neck? It's hammer and chisel, very strong, yeah? So it's very unlikely it could happen. So those are the 3 or 4 issues relating to this. And I'm looking forward to Jeff making some statements maybe about how common DISH is here, what his experience has been. You know, there's one country in the world where when you get DISH, there is one complication. And the country is Japan. We wouldn't know the incidence of this in this country because I'm sure no one's actually looked at it. But this is where the posterior ligament in the spine, you can see it on the plain x-ray here again, this line here, can actually ossify. And sure, you can do all the fancy imaging and you can show with a CT scan the ossification. It does happen with DISH. It does happen. And so this is the sort of thing that may or may not be clinically apparent when the patient presents, may just have a bit of neck stiffness. Okay? And I've got this one young man here who was only 42 and he was surfing. We do much surfing in Botswana? I have a hat, and it says, "Only a surfer knows the feeling." And of course, when I was in Kenya a few years ago, a very tall Maasai man came to me, "I like your hat. I like your hat." And I said, "You can't have it." He says, "What is this?" Only a surfer knows the feeling. He had never seen water before. How do you explain to someone only a surfer knows the feeling? He didn't get my hat back. All right, but this man had a surfing injury, and you can see that he's clearly broken those hyperostoses here. Okay. Now they do develop clefts in them normally. This is a normal finding in them, so you don't want to confuse those with fractures. So there's an example where an x-ray, you don't need a fancy CT or whatever, you can recognise the DISH and you can actually make a good clinical appraisal of that person. Now I hope you can swallow that. A St. Louis beer top is that what people drink here, beer, St. Louis beer? Yes? In Australia, yeah, we like to open it with our teeth. And someone hit this man on the back while we did this. Yeah. Now, the reason I bring this one up is that there's a particular finding on a plain X-ray which is important, and that is the soft tissues in front of the spine. Okay, and you can all see this area here. Now, why do I bother bringing that up to you? Well, the reason is that again, in a setting of trauma and you don't have access to CT, this is obviously going to be a significant bleed. This is blood. And it usually means they've had a significant injury in the anterior part of the spine. And this particular man, all he had was a very small fracture. But of course, that's an X-ray that can be read by a lot of people, and you need a plain film, that's all you need. And of course, we do know, even in the whiplash literature, that this is one of the findings, that if someone's had a neck injury with this swelling, their outcome is reduced in terms of their neck symptoms. Okay, so we call it the 7 at 2, the 2 at 7 rule. All that means is that C2, it shouldn't be more than 7 millimetres. And if you went down to C7, it shouldn't be more than 2 centimetres. That's the normal finding. Okay, try this one, okay? It's a patient, 25-year-old man, who was actually a man who, how can I explain it? He had had a surgery 3 weeks before, tonsillectomy, and his tonsils at the back of the throat, and you can all see he's got prevertebral swelling. Okay, went to a chiropractor, and I put a normal up alongside it here to test you. Okay, radiographers, anyone here like to have a go at this? A radiographer from the hospital here, who went to Australia and did his, there he is. This young man here, I'm sorry, your name? All right, I'll just call him Ben. He trained in Australia not more than 2 kilometres from where I grew up, and probably played football on the field I did. So, you know, we have some connection with that. All right, so, I mean, I am sure, am I right, that many times you take an X-ray and the doctors ask you for your opinion, correct? Mostly. Never say that to doctors. Yes, occasionally. Okay? All right, so you've got the eye, right? You've got my eyes. Okay? And the eye sees what the brain knows. Yes? The eyes see what the brain knows. And you've looked at a lot of X-rays, and they're normal. So what's the key sign here? What's wrong here? He doesn't have, I'm getting the telepathy. He's lost bone. He's lost bone on the end plates. And it's across the disc, and this makes an infection. This makes an infection, okay? Now you see lots of TB. I saw a case yesterday with Jeff, yeah? And this is what we look for. So a plain X-ray here is actually very diagnostic. We know what's going on. If they're here in Modalities, you can send them to Gaborone pretty quickly, okay? Or have one of the spinal surgeons look at it. Correct, okay. So this is an example of a disc infection solved by plain film, yeah? Okay, we'll just move on a little bit. Here's a case of TB, okay? In Australia, we have had 4 cases of spinal TB in my hospital in 15 years. Okay? 15 years. I am very pleased that yesterday, on the 5th case I looked at, with Jeff, I found a case of spinal TB. And when we get it, there's huge discussion. Okay? Let me just say this. TB, or Pott's disease, okay, is a disease where they can go for many, many months before something enough happens for them to come in. And by that time, this CT here shows you everything that it does. First thing is that it is multiple levels. Usually multiple levels. One word so it's there with a single level. Multiple levels, the bones are white. They are sclerotic. This is a chronic process. Chronic process. And there is destruction of the bone anteriorly, and that's classic for TB. It's classic for TB. Anterior erosion of bone. I know that as a radiologist, okay? And I can make that diagnosis. And quite often you can do this on a plain film. Okay, all right. Let's see here. Yeah, this is quite an interesting little video of someone who, I don't know if we'll go, no, it's probably a bit slow on my stick, that's okay. So how do people get TB of the spine. Now, how does this relate to imaging? What I'm trying to do here is to show you a bit of knowledge that can be helpful, can be dangerous too, yeah? But how does TB get to the spine? Well, the answer is it gets by blood. And there's a system of veins around the spine which communicate with the pelvis, okay, with your lower legs, and it's a different system to your vena cava, okay? Now that means the blood coming back from your legs doesn't necessarily have to go back directly to the heart. It comes back around the spine. And that's how TB gets to the spine, okay? By this system of veins, deposits into the marrow space, and you get your typical infection. Now I know that everyone here is very aware of HIV, okay? We've seen that with our discussion in the Ministry of Health. You know it in the literature, and certainly, I know Jeff in his experience has found that as well. The interesting thing is I did a quick search and found a very good article on the complications of HIV. And I was asked this in the last couple of days 4 times by people I met in the hospitals. And the question was, we see lots of HIV patients. Why do they get so much back pain? Why do they get so much back pain? I am not an epidemiologist, okay? And I don't know all the answers, but I will say this, that if I know the patient's got HIV and they've got back pain, there are 3 questions go to my mind. The first one is, look at this figure here. Oh, sorry. Oh, there we go, that was good. That was really good. That's a radiologist at work there. Hang on, what did I do here, Jeff? That's supposed to go back. I lost it. No, it's all right. We're away. It's okay. There is a special way that when you manipulate someone, you have to draw your hand up like this and give a specific thrust. And that's what I'm doing. I'm fixing. Okay? All right. Okay, so look at this figure here. 45 to 67% of HIV patients have osteoporosis. The most common probable method of them presenting is they've got osteoporosis and they do what? They fracture. Okay? So if I know that, that's what I'm going to look at. We'll talk about osteoporosis in a moment. Second thing, I know they're prone to what? Infection. So guess what I look for? I look for the loss of the end plates. Yeah? Okay? And third thing is we do know they're prone to malignancy. And the most common one, of course, is lymphoma. So I look for destruction as well. Okay? We have a large HIV population at my own hospital. Okay? And in the interim, since we've been in Gaborone, I've had one of my residents go to my database and send me images of a couple of HIV patients for you. Okay? Technology. The most common thing we have seen is infections in the spine, but also in the sacroiliac joint. Now, do you do x-rays of the lumbar spine? Yes. Do you include the sacrum and the sacroiliac joints? Yes, you do. Okay? Important to remember, and this is something because if you're in control of the patient right there, if they've got low back pain, you should do the specific view of the sacrum, the tilt view up. In fact, at the Canadian School with Dr. Moss is, we instituted over 20 years ago that view should be a routine view. I would suggest that with HIV patients, we need to look at the sacroiliac joints. Why? They're the second most common place for infections. Okay? And what do you see? You see SI joints, they've got little erosions, little loss of definition. That's the key thing. Okay? Loss of definition, just like in the spine, we lost that bone on each side of the disc, same thing here. And of course, if you do the fancy imaging, the MRI, remember, what does MRI stand for? It's not the Ministry for Radio, no. Sorry, that's what I see. Everything starts with an M is ministry, right? It stands for magnetic resonance imaging, yeah? Okay? Sometimes I get called Mr. I. Mr. Imaging, right? But it stands for more radiology immediately. No. MRI, of course, is a very sensitive and very specific technique, yeah? And so I just have to make sure that we get that message across, right? We're all doing HIV. So what am I doing here? I'm leading you down a track that you get asked a lot of, okay? And you're asked, from an imaging perspective, what's the imaging we should do? It'll be plain films 9 times out of 10, I have no doubt. But the clinician has to make up their mind. Is it a red flag? Am I worried about it? Maybe the plain film didn't show it the best. Maybe it was a big patient, the quality of the film wasn't the best. and then they have to make the decision. Yeah? And it's a tough one. It's a tough one. So that's where I'm leading you with this. This is a patient who's got HIV, presented with back pain, and it's an MRI, and I apologise for those who haven't looked at much MR. I think you can all recognise that this is looking at the patient as they're laying face down. And here is the kidney, here is the spinal canal with the fluid around the nerves coming out. And as we make our way to the back, to the skin, what you're going to see is all this whiteness here. And of course, this is the other condition of HIV called myositis. They get infections in the muscle. There is no way on a plain X-ray you'll see this. And even on a CT, you probably won't see this. You need the more radiology immediately. And this is the issue that you face. In a community like yourselves, where you've got plain film, MRI down the road, either way, okay, when does the patient, pay their 20 pull or whatever it is to get the bus? Or it's a difficult one. It's a difficult one. And I would say to you that the incidence of myositis with HIV patients is almost 12%. Okay? In other words, 1 in 8 patients present with back pain will have a degree of myositis. Okay? Where did that come from? It comes from some literature which is available. Okay. All right. So is everyone with it so far? I mean, when you look at this in cross-section, this is what you see. Okay? In cross-section here, you can quite clearly identify that the patient's got lots of fluid and edema in this muscle. Okay? And this is what we see here. And fortunately, with treatment, they do get better. Absolutely do get better. And the other one, as I mentioned, the 3 things: osteoporosis, okay? We talked about the fractures that happen from that, infection, and then, of course, destructive things, which unfortunately fit into that 1% of back pain, are destructive lesions of bone, which tend to be in most HIV patients either lymphoma or occasionally Kaposi's sarcoma. Okay, just one more message. Bear with me for a few minutes and I'll finish up. I guess osteoporosis is something which really, from an imaging perspective, we think it's fairly straightforward if you've got the tools. Now, there is a machine called a DEXA machine, D-E-X-A, and it stands for Dual Electron X-ray Absorptiometry. Aren't you happy about that? We call it DEXA, okay, for obvious reasons. And that's the gold standard at most places when they do an epidemiology study look for bone density, okay? It would be an absolutely fabulous opportunity to get a DEXA machine here in your community, and we could start to look at, for example, the osteoporosis situation with HIV patients, all right? And so that could be considered a priority. The plain films, of course, may not be always that useful. What we're concerned about with osteoporosis, and I've just put up a CT because it's a little easier to see, is that the cortex is thinned. You obviously are prone to fractures, okay, which you can see in this patient here. And there are some other subtle findings. I'll take you through them. Let's move on here. Sometimes the trabecular patterns in the bone are a bit more prominent. It's been called pseudohemangioma because it looks like a hemangioma, which is a tumour of the spine. It's a benign problem. But here's a DEXA, and basically you plot their bone density against the known population, and I guess that could be an issue here in Botswana. You probably don't have a reference population. And I apologise, I don't know the literature and that here. You have to have a normal population before you can call someone abnormal, yes? I'm normal, you're abnormal. Okay? That's not a good reference, is it? Okay? So you need to have a normal population, and that may be something that hasn't been done yet. One of the things you do see is a very characteristic deformity, and these end plates have this shape to them. Does anyone know what's that called? These are called fish vertebrae. Okay? Now, this is a specimen here. It's actually called fish vertebrae because if you took the skeleton of a fish and x-rayed it, the end plates of the vertebrae look like that when you get osteoporosis. Okay? So if you've learnt one bit of esoteric nonsense today, it's that, okay? Fish vertebrae. And you can get them in little fish, okay? In Australia, we have crooked fish, okay, with a scoliosis, but you can still see the end plates there. Yeah, that was a fish I caught off my house there, yeah. Okay, all right, okay, I might just finish up there. Let's see if I can, how do I get out of this thing? How do I get out, Jeff? And I'll just finish up for time. Yeah, oh, there we go. Thank you. Okay, so I'll just finish off just with. Oh, hang on, it didn't work. I pressed the wrong one again. Sorry. Just because of a bit of time. So I'll just finish up, perhaps we'll just finish off with this. Yeah. Okay, so what have I tried to do? What I've tried to do there is give you an introduction to how imaging works, you know, with plain film, CT, MR. Each has got pluses and minuses. If we're in the plain film world, we have to recognise some of the deficiencies, but at the same time, not get too carried away with that. I mean, in an ideal world, here in your facilities, say out here in this part of Botswana, a CT scan would be fabulous. I mean, it's not just for spine either, okay, because it has lots of flexibility. Certainly a bone densitometry would be helpful, yes. Do you need MRI? Absolutely, if you want to get the gold standard. The gold standard of imaging of the spine is an MRI, okay? What's the best beef in the world? Botswana beef, yeah? What's the best spine imaging? MRI, right? They're the same, yeah, that's what you want. So I'll just leave you on that, and I hope that's given you some insight into some imaging of some spinal issues, and I hope, like this patient, I've given you some insight to your the role of radiology out here. For those that don't know MRI, this is a brain, and you might just notice that the patient's looking the wrong way. I won a prize for that. It's called a patient with insight to their disease. Yeah.